Hello everybody. It's my pleasure to have you here on this video lecture. I'm Vygantas Rutkunas. I'm prosthodontist from Vilnius, Lithuania. And today I will be glad to discuss with you some current status of the digital implantology and prosthodontics and some future trends. This video lecture is brought to you by Digitorum, which is involved in dental education, also research services, digital lab services, and many results that will be presented in this presentation is done together with my really enthusiastic colleagues from the Digital team, Digital Oral Rehabilitation Research Group team. So we can go to this internet site and find out more information on the newest results from our research and lab work. Well, the most fascinating part of the digital workflow most probably is the synergy between the surgical techniques that can be planned using the digital tools and the digital prosthodontics. So we are applying quite oftenly to, in cases like this, to go from really complicated situations in a well-planned way through the fully guided surgery and complete the cases with restorations produced without any surprises. This is a great value for us. So this is the value of prosthetically driven planning. And for these to plan the prosthesis, plan restorative phases, we can use analog instruments, we can use purely digital wax-ups, or we can combine them. We can do digital wax-up and do 3D printed model, and we can do analog wax-up on the 3D printed model. As it depends on you, what you prefer, but the ultimate aim is to communicate this, the treatment, communicate all the treatment aspects with a dental technician and with your colleagues and to reach good result in a predictable way. As a standard technique, we can use freehand surgery, and for the small cases, this most probably is sufficient technique. However, freehand surgery, as it was shown by some research, depends on the number of the missing teeth. Do we have the teeth in adjacent area, even on the quadrant, on the mouth opening of the patient, and on many aspects. So it's not always easy to achieve optimal implant position with a freehand surgery. So in these cases, we can end up with less favorable prosthetics, and in some of the cases, it can have clinical significance when we talk about long-term results. And when we have a more complex cases, it's the implant direction, implant position is even more critical. Well, after the implants are osseointegrated, we want to take a really accurate implant impression. And there's plenty of research and systematic review showing that when we splint impression cuppings, we get better results in terms of the accuracy. However, if your implants are really high angulation, are not parallel, the splinting with some of the systems, with some impression cuppings, it's difficult to achieve, or maybe it's impossible to achieve. So it can affect the angulation of the implants, can affect the accuracy of the impressions. It's not easy to address this when you do freehand surgery. So the recent paper from our group published recently confirmed these findings. So we, for the same set of patients, we produced 3 or 4 unit implant-supported restorations through conventional and digital workflow. And then we tried to evaluate the passive fit of these restorations and to compare, is the passive fit with the conventionally fabricated restorations and digitally fabricated restorations. So digitally, I mean model-free, the 3D printed models were not used in this case. Are they comparable? And also we checked other factors that could be associated with a misfit, less than optimal fit. What we found that with the implants, when the angulation of implants between the implants increased, so in this case it was more than 10 degrees, we found more restorations with a less optimal fit. So this is also a big value of fully guided surgery. Fully guided surgery allows us to communicate also some of the prosthetic decisions for the dental technician. What's the position of the implant? Which titanium base we can use, the lower, the higher profile. Maybe we can plan some bone profiling during the surgery. So it's a very good communication tool between the dental technician and the dentist, and these results are good for the patient. Also, it allows us to produce some prosthetic components before the surgery, either temporary or final ones. That could be the custom abutments or even final restorations in some rare cases. So certainly there's a big value of fully guided surgery from the prosthetic part, and even with a pilot drill guided in some of the cases we can have a more favorable outcome, as we see here. So when it comes to fully guided static surgery, we have many designs of the surgical stents and different techniques. And of course, needless to say that they will provide different levels of accuracy. And this is a really important topic, and there are some good systematic reviews published on the levels of accuracy we can expect with a static guidance. And there is another option for us, very nice to apply in the clinical field. It's very flexible. It's a dynamic navigation surgery. When we can do CBCT, and after 5 or 10 minutes we can have implant positions plan, prosthetics plan, and right away we can proceed with the surgery. So this is a big advantage, and another advantage is that during the course of your surgery you can adjust, you can modify the implant position if it's needed, what you cannot do with a static surgery. Well, the disadvantage in my eyes is that with a static surgery we can communicate better in the prosthetic phase, and also we can we can connect better with producing some prosthetic components before the surgery, custom abutments or temporary restorations. But anyway, this offers a nice advantage for the clinician and great flexibility. Coming back to the static surgery, static guidance, we also know that guides that are having a support to the teeth, teeth-supported guides can offer better accuracy. In some of these cases, even though we have a terminal dentition, it's a great approach to retain these teeth for some time. And of course, it's good for the patient And we can also use this teeth as a support for fully guided, during the fully guided surgery, as a support for the guide. But in some of the cases, we can modify the protocol how we do CBCT, because we need to have some reference points in order to superimpose, to align the CBCT and intraoral scans. Because in CBCT, for example, temporary restorations, they will not be visible. And the way you design the surgical guide, it's also there are so many variations, so many types of them, but there are some certain requirements that the guide must fulfill, but I will not go into the details too much here. And let's see the patient. So in this case, we provided immediate loading in the lower arch and early loading in the upper arch. So you see here the situation, clinical situation. So the CBCT is done, intraoral scanners are done, and the implant position is planned based on our prosthetic plan. And we can also plan the angulations. We can plan the prosthetic components that we will be in need. If your software allows you to use generic abutment, it's great. If your software allows you to use the real multi-unit abutment, then it's... So with the upper arch, we proceed with a fully guided surgery. As you see here, unfortunately, in some of these cases, we need some minor or moderate bone augmentation, so we cannot proceed with the immediate loading in these cases. But this is the beauty of digital workflow and digital technologies, that it offers us new possibilities. And this is one of them that we're working with our research team. We use the bioprinter to 3D print standard shape or custom shape bone substitute, bone scaffold that we most probably in the future will be able to combine with a guided surgery or some simple surgery. So again, let's see the next clinical stage, and we see the advantage of the fully guided surgery in this case, because we already know which multi-units exactly we will be using, and we don't see any big problems in these situations. What we were able to produce with the brilliant work of the lab technicians, smart minds, the temporary prosthetic components that were fabricated before the surgery. So design was that we fabricated the custom abutments made from PMMA, and also temporary restoration also made from PMMA. So at the uncovery stage, we are able to place these custom abutments which were fabricated before the surgery. And with this, our relining procedure is more predictable, is not that complicated, is not that messy. So we can go with relining, and we can provide the patient and the temporary solution in a quite fast and comfortable to us and the patient way. Okay, so let's move to the lower jaw. We see that in this case, we also try to preserve some of the teeth to aid the support of the guide. In a free end edentulous area, we're using stabilizing pin. Otherwise, the guide was supported by the teeth. So here's the surgery. And with a fully guided surgery, we control the implant depth, implant direction, and also the rotation, which is important in those cases when we use angulated implants. And again, Pre-surgical prosthetics were done, were milled with some support legs to stabilize the PMMA bridge during the lining procedure. So right after the implant placement, we proceed with a relining of the PMMA bridge, and the patient is immediately loaded, and has an early loading in the upper arch with temporal restorations. And there's no surprise that of course, we have to adjust occlusion. It's not everything is perfect. So here's the case. Well, the healing progresses, and we are able to evaluate the phonetics, the occlusion, aesthetics, cleaning ability of the patient, and many other important factors. However, we see quite nice result with temporal restoration, and then it's not a brainer to reproduce this in the final restorative materials. We are having a good start point for the prosthetic procedures. So this is the value. Well, for the less extensive cases, we can go with the early loading. It's very efficient in a dental clinic. When you place the implant stability is good, and after 2 weeks during the suture removal appointment, we can introduce the final restoration. Of course, you can do immediate loading, but in this case it's a little bit more stressful for the clinic, for the lab to produce everything through the course of 1 day. So early loading is one of the nice options what you can apply. So here's the case. We are planning the implant positions in the software, and of course we have quite many data there, and we have this color map on the implant surface, which sometimes looks just for fun, but it's in some of these cases, especially when we go for early loading, it is of value, because we can appreciate the bone quality before the surgery, and we can also modify our surgical protocol to get better implant stability and to be on the safe side with early loading. What we can do, and what is not usually done before the surgery, we have to select the shade of the future restoration before the start of the surgery. So this was done. The implant surgery, fully guided surgery, was done. We for the fixed partial denture case, we are pretty sure that the angulation is well, in this case, less than 10 degrees, and we will not have any surprises during the impression taking if you go with conventional and splinted ones, or during the fitting of the final restoration. And after the suturing, we make the digital impression, and we proceed with the production of the final restoration. And when the patient will come back for us for suture removal 2 weeks later, we will be ready to provide him or her with a final restoration. So this was done in this case. 2 weeks later, the restorations were inserted, X-rays were taken, and as you see, these restorations are in a fully functional loading, and it's one of the options you can do with the aid of fully guided surgery, with the aid of digital technologies. And well, this, as I have already mentioned, increases the efficiency of your practice, and also offers some biological advantages for the soft tissues. And we are looking into this, and The preliminary results, we can see that with the early introduction of prosthetic component, we have a quite nice outcome of the soft tissues. And of course, we can look deeper into the direction, the number of the fibers, so we can better compare in a more quantitative way to compare different groups. When we introduce the prosthetic component after some time in delayed, when we do it immediately or at the early stages. And the prosthetic component, the material of the prosthetic components is also important. And there's a separate topic on this, and I will not go too deep here, but yes, it could have some, well, we can debate on is that difference will be clinically significant, and also the polishing quality of these surfaces are really important. And more than that, not only polishing but also cleaning before delivery, it's also very important. And you can for sure can find some good literature sources on that. So to sum up this part, the most beautiful part of digital workflow is the possibility to combine, to get the synergy of the surgical prosthetic procedures, to match them and to get very good results and to increase your efficiency. So with this, I would like to thank for your attention. Also, I would like to thank all the research team. They were involved in many research projects we are currently working, and you have seen them in this presentation, and we are able for sure to provide more results which you will be able to use in your clinical practice.